Thanks, Dr. Foley. Actually, this talk it's a lot about vascular surgery, but it's also about trauma. So it kind of melds my two main interests into one talk. And I think in trying to find a vascular type of talk that would be generalizable, I think this is a topic that can be something that general surgeons, vascular surgeons, trauma burn surgeons, orthopods, plastic surgeons, even pediatrics and transplant surgeons all have to deal with this problem, and so I thought it would be good for this venue. I don't have any financial disclosures. So the outline of my talk, I'm going to talk about the indications, in particular focusing on three main indications: vascular indications, diabetes, as well as trauma. How to determine the level of amputation, because that's going to be important for the patient as far as their functional outcomes and things like that. Technical details of primarily the two main major lower extremity amputations, transtibial below knee amputations and transfemoral or above knee amputations. I'm not going to talk about foot amputations or more proximal amputations like hip disarticulations because they're pretty uncommon. I'll talk briefly about post-amputation complications, in particular reamputations. I'll spend a lot of time about dressings, which is something we don't think about, but there's a very large literature about it, and I think it's pretty interesting. I'll talk about the outcomes after major lower extremity amputations, then I'm going to spend some time on a paradigm shift that I'm going to make a case for. So, like with many advances in surgery that have coincided with major conflicts and war, amputation surgery is really no different. There was an uptick in amputations around the time of World War II, Korea, and Vietnam, and it really seems like the golden age of amputation surgery spans these decades, the 1940s through the 1970s. There has also been an uptick in the last decade with the Operation Iraqi Freedom and Enduring Freedom, and I think we've entered a new golden age of amputation surgery, if you will. I'm going to talk a little bit about this gentleman here, Ernest M. Burgess. He was in many ways the driving force behind this golden era of amputation surgery and was a true giant of modern surgery that I think is in a lot of ways unrecognized. Dr. Burgess was an orthopedic surgeon during World War II, and as the chief of surgery at Tripler Hospital in Honolulu in 1944, he witnessed the inferior quality of amputation surgery, which had a profound effect on his career. I'm just going to read this quote from him from 1969 when he was well into his career. Amputation must be considered plastic and reconstructive in nature. The need to create a dynamic and sensory motor end organ should be foremost in the surgeon's mind. The atrophic, wasted, bony, below-knee stump so commonly encountered in years past is no longer acceptable. This is actually, I think, a radical change from how amputation surgery was thought of in the beginning part of that century. Dr. Burgess entered private practice in Seattle, Washington, where he helped pioneer total hip replacement, but his greatest contributions as a physician and as a surgeon was to the field of amputation surgery and prosthesis. He popularized the long posterior flap amputation that is the technique most commonly used for transtibial or below-knee amputations and is often referred to as the Burgess technique. In 1964, Dr. Burgess attended an international conference of prosthetics in Copenhagen, where he was inspired by presentations by Drs. Michel Berlemont and Marian Weiss of Warsaw, Poland. Based on this inspiration, he helped found the Prosthetics Research Study, or the PRS, in Seattle, Washington in 1964 at the request of the Veterans Administration and in collaboration with their Rehabilitation Research and Development Service. He became the director and principal investigator of the PRS, and the PRS developed a number of different innovations, including the immediate postoperative prosthesis, or the IPOP, which I'm going to talk about later in this talk, which is a technique in which the amputee is fitted with a prosthesis right after surgery and begins the rehabilitation right away. He also invented the Seattle foot in 1984 and the VA Seattle ankle, and he's modeling, I believe that's the Seattle foot right there. It might be the Seattle ankle, I'm not sure. This has been used by over 150,000 amputees worldwide. They've also conducted diabetic footwear studies to help reduce amputation rates due to diabetic foot ulcers. He also applied CAD/CAM, or computer-aided design and manufacturing technology in the 80s to prosthetics manufacturing, which made prosthetics manufacturing more high quality and affordable and more easy to distribute to patients. He also produced some CD-ROM software which helped teach prosthetics to over 49 universities around the world. In 1989, he founded the Prosthetics Outreach Foundation, a nonprofit medical service providing high-quality prostheses to amputees around the world, and he established one in Vietnam, which has led to a self-sufficient prosthetics program, which has supplied prosthetics for over 10,000 children and adults. So truly a great surgeon, and he's going to play a big role in my talk. So what are the indications for major lower extremity amputations? The three main ones are peripheral arterial disease, which is what we think of as the most common indication, and also severe infections related to diabetes. And these are oftentimes overlapping. I think the third major indication is trauma, and so I'll focus on those three. Some less common indications are malignancy, burns and frostbite, compartment syndrome, Charcot disease, and complications of paraplegia. So in 2005, there were 1.6 million limb amputees alive in the U.S., and this is expected to double by the year 2050. Half of the amputees in the United States lost their limbs due to what was called dysvascular disease, which is primarily arterial disease. What is interesting is that the incidence that over 80% of amputations are a result of vascular disease. So the fact that there's only a 50% prevalence shows the high mortality that occurs for patients with vascular disease that undergo amputations. This figure is from TASC, or the Inter-Society Consensus for the Management of Peripheral Arterial Disease, and this demonstrates the high mortality associated with critical limb ischemia and amputation. You can see in this graph, this is for patients who present with limb-threatening ischemia, which is about 1% to 2% of patients with peripheral arterial disease at any given time. And you can see 25%, their primary treatment is an amputation, 50% get revascularized, and then 25% get medical treatment only. This is relatively old data, so this is probably different today. 1 year later, you can see the results are pretty dismal. 25% of these patients are dead, and 30 are alive and amputated, so greater than half these patients are either not alive anymore or they've had an amputation. Only 1/4 or 25% have their limb and their limb ischemia is resolved. The second major indication for lower extremity amputation is diabetic ulcers and infections. While many of these are related to underlying ischemia and large vessel disease that overlaps with the previous indication, I think these infections, these also stem from trauma, neuropathy, and poor diabetic control, and so I think this should be thought of as a different entity to isolated peripheral arterial disease. 2% of diabetic patients develop foot ulcers per year, and about 15% will have them in their lifetime. So and if you multiply that by the number of patients with diabetes, it's a huge problem. Foot ulcers precede about 84% of lower extremity amputations in diabetics. Of the 70,000 lower limb amputations in the VA, the majority of them are due to diabetes as well, and I think we see that in our practice here. The important thing is that despite the scope of this problem, many of these patients are candidates for limb salvage, and early referral and aggressive debridement and IV antibiotics, as well as revascularization, can reduce the need for above ankle amputation by at least 50%. The first two populations, the diabetics and patients with vascular disease, represent the vast majority of new amputees. However, limb loss secondary to trauma accounts for about 45% of the prevalence, over 700,000 patients in the U.S. population in 2005. The number of lower extremity limb amputations per year, however, is not nearly as common, estimated by the National Trauma Data Bank to be about 350, but that's likely a gross underestimation. These patients are a unique population because they have a longer life expectancy, and so they're going to be living multiple decades with their amputation and with the function that they have. I really like this picture. This guy's really must be a motorcycle enthusiast to continue with amputation. As mentioned earlier, there is now a new surge in combat amputations with the conflicts in Iraq and Afghanistan, most of which are major lower extremity amputations. These patients are primarily young, healthy males with excellent rehab potential and a long life expectancy. This is Jared Fields. He's a U.S. Army world-class athlete program Paralympics sprinter, and he won the 100 meters with a time of 12.15 seconds with this prosthesis that you see here. And he's kind of one of the poster childs, if you will, for the new paradigm in the Army for treating amputees. So why do we perform amputations? Here I've listed the main indications for amputating a limb as put out in the task guidelines in patients with vascular disease. So it's important to think of things as primary amputations and secondary amputations. So a primary amputation is defined as an amputation of the ischemic lower extremity without an antecedent attempt at revascularization. So the patient presents with a problem and the primary treatment is amputation. The reason to do that, unreconstructible arterial occlusive disease, so the patient's not going to be able to heal their wound or their infection. Significant necrosis of significant areas of the weight-bearing portion of the foot. Fixed flexion contractures of the leg that can't be repaired. And a terminal illness or very limited life expectancy because of comorbid conditions where the rehab potential for the patient is just not there. Secondary amputation is performed after you've done an intervention. Again, the majority are due to unreconstructible vascular disease, but also due to persistent infections despite reconstruction, or the limb continues to deteriorate after reconstruction and the patient would be better off functionally with an amputation and a prosthesis than their existing limb. The goals of amputation are to relieve pain, the complete removal of all disease, infected, or necrotic tissue, and the achievement of complete healing and the construction of a stump that is suitable for ambulation with a prosthesis. Antecedent surgical procedures are not felt to worsen the ability or the overall condition of the leg and is not felt to lead to a higher level of amputation. So it is worth in patients who don't have these indications on the left to attempt some kind of an intervention if possible. You're not really burning any bridges. There are scoring systems to assist with the decision to perform a primary amputation in trauma, such as the Mangle Extremity Severity Score or the Gastillo classification for open fractures, but there aren't any for vascular disease, and this I do think is an area where there's a need for research. So it is the implicit goal of amputation to obtain primary healing of the lower extremity at the most distal level possible. And the reason why is that the energy expenditure of ambulation increases as the level of amputation rises from the calf to the thigh. Preservation of the knee joint and a significant length of the tibia permits the use of lightweight prostheses, minimizes the energy of ambulation, and enables older and more frail patients to walk independently. Therefore, the lowest level of amputation that will heal is the ideal site for limb transection. So you can see in this graph here, for below-knee amputations, the energy expenditure rises as you go from long to average to short. And interestingly, a short BKA is as much energy expenditure as a bilateral BKA. I think the most striking thing is the difference between any of the below-knee amputations and the transfemoral amputation, which surprisingly is a much higher energy expenditure even than a bilateral below-knee amputation. This is why, especially in older patients, it is imperative to attempt to spare the knee as much as possible. This likely is the reason why only about 50% of older patients who have an above-knee amputation are able to walk eventually. So what options does the surgeon have to help determine the level of amputation? The best initial test is the physical exam. The presence of a palpable pulse in the major artery immediately above the level of amputation gives a near 100% likelihood of primary healing. However, the absence of a palpable pulse is of little clinical value, as many amputations will heal in the absence of palpable pulses, and many studies have corroborated this. Arteriography is also a benefit to evaluate the ability to revascularize, if not for limb salvage itself, then to facilitate amputation at a lower level and improve function in the amputee. I'll talk briefly about these last four adjuncts: the ankle, can you even see this? Ankle pressures, skin pressure, TCO2s, and also surgeon judgment. So Doppler ankle pressures are used commonly in peripheral arterial disease. They're non-invasive, they're inexpensive, they're easy to get. However, they can be unreliable in patients with arteriosclerotic disease because of the inability to compress heavily calcified vessels. Where ankle pressures probably have a more important role is in the healing of diabetic foot ulcers. For example, an ankle pressure less than 50 millimeters of mercury in many studies has been found to be insufficient to heal minor amputations for diabetic ulcers and leading to amputations above the ankle. Transcutaneous oxygen is a well-documented technique reflecting the nutritive flow in the tissue capillaries. It was originally designed to monitor blood gases in neonates, but is now used to measure skin perfusion. Many factors can affect the TCPO2 measurements, including local edema, thickness of the epidermis, and leg dependency, so it has to be taken with a bit of a grain of salt. Skin perfusion pressure, as measured by radioisotope washout, has been shown to be a reliable predictor of amputation wound healing. Currently, the technique is a laser Doppler probe that is placed under a blood pressure cuff, and it's been shown in several studies to be a reliable adjunct in determining the level of amputation. Despite all of these adjuncts available to help the clinician, there's still really no substitute for the experience and clinical judgment of the operating surgeon. The selected site is evaluated in the operating room by the surgeon, who observes the appearance of the subcutaneous tissue and muscle and the presence or absence of bleeding from the cut edges of the tissue. The appearance of ischemic or necrotic tissue or the absence of bleeding usually means that the amputation needs to be attempted at a higher level, and a lot of this is determined intraoperatively. When made by experienced surgeons, clinical determination of the amputation level results in uninterrupted primary healing in up to 85% of below-knee amputations and up to 95% of above-knee amputations. And in some high-volume centers, the healing rate for below-knee amputations can be as high as up to 98 or 99%. So I'll go over a bit of the technical details of the two major operations, the transtibial amputation and the transfemoral amputation. And I think I learned a lot actually from going through this, despite having done a few of these operations, that there are some technical details that can be added or paid attention to improve, possibly improve outcomes in patients. I'll briefly talk about the knee disarticulation of the through-knee amputation and the Ertl procedure. So the posterior flap technique for the transtibial amputation was first described by Kendrick in 1956, but was popularized by Burgess in the late 1960s, and both names have been associated with this procedure, most commonly Dr. Burgess. The procedure begins with determining the length of transection of the tibia. The anterior skin incision is marked about 1.5 centimeters distal to the anticipated tibial transection, and this is the anterior skin incision, and that creates a short anterior flap. The anterior incision is marked out as 1/2 the diameter of the calf at the level of the anterior skin incision. So that's this right here. The horizontal portion of the posterior skin incision is measured as the total diameter of the calf at the level of the anterior skin incision plus 1.5 centimeters. The muscles of the anterior compartment are then divided, and then the neurovascular bundles containing the anterior tibial artery and the deep peroneal nerve are ligated and divided. You can see that here. The tibia is then mobilized in the subperiosteal plane and divided 1.5 to 2 centimeters proximal to the skin incision, again to create a anterior flap. The fibula is then divided. That's shown right here. After bony division, the posterior muscles are stripped off the bones, often with an amputation knife, and the posterior skin flap is completed as marked. The perineal and posterior tibial vessels are controlled. One important step is that the tibial nerve can be separated and dissected where it emerges underneath the tibia and then divided as high as possible to avoid creating a neuroma at the point where the prosthesis is going to form contact with the stump, which can lead to pain. The initial sutures are placed between the tendons of the gastrocnemius and soleus muscles and the anterior periosteum of the tibia. and the surrounding fascia, thus creating a myoplasty. The remaining deep fascia is closed with interrupted sutures, absorbable sutures, and then the skin is closed with vertical mattress sutures or staples at the discretion of the surgeon. The transfemoral amputation is predicated on determining the level of bony division, as you can see right here, and ensuring long enough anterior and posterior soft tissue flaps to cover the end of the femur. The skin flaps can be equal anterior and posterior. It's kind of fish mouth flaps, oblique flaps, or sagittal flaps, and this is really based on the quality of the surrounding tissue, previous incisions, and kind of the geometry of the patient's leg. The bone should be divided proximal to the skin and muscle a distance of about 1.5 times the diameter of the thigh at the level of amputation. So this provides adequate length of muscle and skin to cover the femur. The vessels are identified and ligated, and the femoral and sciatic nerves, again, are retracted inferiorly as much as possible, and then ligated and divided as high as possible, allowing these nerves to retract. And again, this is to prevent or decrease the likelihood of a neuroma forming right where the prosthesis is going to sit, which can lead to pain. Fascial closure alone can be used to close the wound, followed by skin closure. Alternatively, various techniques have been described for muscle stabilization, namely myodesis and myoplasty, and I'll talk about both of those. If the major muscle groups are not stabilized at the site of the amputation, they will retract, and this can result in a weak and often painful residual limb. The femur can drift laterally and forward, and that's called femur drift, and you can see that here. This femur is where it should be sitting here in the middle, is now drifting laterally and anteriorly, and this can push against the prosthesis and increase weakness in the limb and also poor fitting and pain. This femur drift can also occur even in non-ambulating patients. Muscle stabilization provides a stable functional amputation stump, and this improves the prosthetic management and walking ability postoperatively, or at least is felt to do so. So this is a drawing of a myodesis, and then this is, I hope that projects well, this is an actual myodesis being performed in a traumatic amputation. So myodesis involves stabilizing the thigh muscles directly to the femur, just proximal to the bone amputation level, usually by drilling small holes in the femur to allow through and through suture of the quadriceps to give good fixation of the muscle to the bone and prevent retraction. The International Society for Prosthetics and Orthotics, or the ISPO, at their consensus conference on amputation surgery in Glasgow, Scotland in 1990, recommended myodesis as an important integral part of the surgical procedure, and they recommended that it should be carried out as much as possible due to the poor clinical and functional results of traditional techniques for transfemoral amputation. This is really despite any data existing at that time in 1990, either supporting or not supporting myodesis. Subsequently, a group in Dundee, Scotland, who were prompted by this consensus statement, did a small study, and it's really the only study I could find about myodesis. They developed a technique for myodesis for transfemoral amputation and studied it in 14 elderly vascular patients in Scotland. They were followed for 40 months, and 80% were still using the prosthesis at that mean follow-up time. There was 100% primary wound healing, and 2 patients did undergo further revision surgery for delayed stump problems. This procedure may be particularly suited for the elderly vascular patient whose stumps are often shorter and of poor bone quality. The low rate of stump problems and consequential revision surgery also enables a more comfortable stump for non-prosthetic users. Myoplasty involves suturing the major muscle groups. As you can see here, there's 4 basically groups of muscles here, and it's suturing the muscle groups opposite to each other, overlapping them over the head of the femur. In order to be effective, the sutures must involve the periosteum to prevent the muscles from sliding over the end of the bone, making the muscle coverage unstable and the myoplasty ineffective. This can be added to a myodesis as well, but I think the consensus that myodesis is better than myoplasty to prevent retraction. I'll talk briefly about the through knee amputation or the knee disarticulation. These amputations are uncommon, representing only about 2% of all amputations. But before the advent of modern anesthesia and surgical technique, This was the favored surgical procedure because of its simplicity and speed and the decreased risk of infection and bleeding. However, by World War II, knee disarticulation amputations had fallen out of favor, and this is because of concerns regarding a bulky, unaesthetic distal limb, poor prosthetic fit, and probably the biggest reason was improved surgical techniques for transtibial and transfemoral amputations that made those more attractive procedures. Through-knee amputations, however, are still an option in select patient populations. This includes elderly patients, spinal cord injury patients, and non-ambulatory patients, with the goal of improving seating and transfer possibilities with the longer stump, as well as eliminating the risk of knee contractures. In a series of 16 high-risk dysvascular patients undergoing through-knee amputation, there is a 70% ambulation rate, which may compare favorably to the historical 50% ambulation rate reported in many series for this patient population. This is the Ertl procedure, a procedure I didn't even know existed until I did this talk. Ertl described an osteomyoplastic operation to induce the formation of an osseous bridge between the tibia and the fibula in 1949. And so what you see here is the femur, a piece of the fibula, and this is bridged across to the edge of the fibula here. The way Ertl described it, you actually use the periosteum to cover this, but using more modern techniques, you can use screws or some other synthetic material to give fixation. The thought is that one cause of stump pain after transtibial amputation is instability between the fibula and the tibia, and this risk is higher when the residual limb is very short. A short transtibial amputation creates a relative absence of the interosseous membrane, and this allows the fibula to abduct relative to the tibia. The goal of the Ertl procedure and its various modifications is to produce a solid synostosis between the tibia and fibula, decreasing pain and increasing the capacity for distal weight bearing in the stump. This operation is primarily reserved for traumatic amputations and is mostly done by orthopedic surgeons. The problem for vascular patients is that the ability to create a synostosis is impaired due to poor wound healing. While some series have reported improved functional outcomes with the Ertl procedure, one large study comparing this procedure to the modified Burgess technique, which is the most common below-knee amputation, found that reoperations were significantly increased due to non-unions in the Ertl procedure, and despite a positive selection bias favoring the Ertl cohort, there were equal infection rates. So it's not commonly used. I'll talk briefly about post-amputation complications. The major concern is the complication rates related to comorbidities. The comorbidities, especially in vascular patients, are significant for coronary artery disease, diabetes, and there is a high rate of myocardial infarction, stroke, and death after major lower extremity amputation, with mortality rates of 7 to 10% at 30 days postoperatively. Some more procedural related complications include wound infections, which I was surprised is actually quite low. I would have thought it would have been higher. And then failure to heal, which in most older studies is about 17 to 25%, although in studies from high volume centers, it really approaches more like 1%. Heterotopic ossification is one risk, especially for traumatic wounds. Joint contractures is a very significant and morbid complication. It occurs about 1 to 4% of the time. And post-amputation pain, including phantom limb pain, which can occur in a variable amount of the time. I'm going to focus on the next slide on reamputations. So reamputations it's a serious outcome after amputation because it exposes the patient to another mortality risk due to another major lower extremity amputation. So the risk is 10% up front, and then you have to do another operation, and so you can assume that they're going to have another 10% risk on the second operation, if not higher. Additionally, the limb is going to be shortened, and the patient's functional outcomes may be reduced as well. Thankfully, the reamputation rate early on after major lower extremity amputation is actually relatively low. Compared to minor amputations of the toe, ray, and midfoot in diabetic patients, reamputation rates, which range from 20 to 30% after 1 year, The reamputation rate for major amputations is only about 5% at 1 year. However, this increases significantly to about 12% and 13% at 3 and 5 years respectively. So now I'm going to spend a significant amount of time on postoperative dressings. This is one thing that I learned a lot about in this talk, and it's something we don't really think about as surgeons, but is talked a lot about in the rehab community. So the one we use most commonly is here is the soft dressing. The soft dressing involves using gauze padding on the wound with the application of soft dressing like an ACE bandage. This picture here shows the common figure of 8 dressing, which we use a lot for edema control. Advantages of the soft dressing include that it's easy to apply, it's low cost because the supplies are pretty much low cost, and there's not a lot of expertise that's needed. The wound is accessible because it's easy to remove the dressing and put it back on, so you can look at high-risk wounds very frequently. The disadvantages, though, can be significant. There is a risk for decreased skin perfusion if the wrap is placed too tight. These patients are at risk for knee contractures. There is poor pain control and decreased mobility because there's no support of the stump because of the soft dressing. Adjuncts to this approach, which are important, are a knee immobilizer to prevent contractures and a stump shrinker, which is placed to decrease edema once you've had enough wound healing. This is the thigh-level rigid plaster dressing. This was initiated by Berlemont in France and Weiss in Poland in the 50s and 60s. And Ernest Burgess brought this technique back from that 1964 conference when he started the PRS. Advantages of this dressing include reduced edema, reduced pain, maybe decreased healing time, but importantly, these patients can start weight bearing because of the rigid nature of the plaster cast, and can even work on early ambulation. The disadvantages are that because it goes above the knee, it's difficult to apply and difficult to take off, and it's got a higher cost because of the supplies and the specialized training that people have to place it. I think this has pretty much been taken over by the shorter rigid dressing that I'll talk about later. This is the immediate postoperative prosthesis, or the IPOP. This was first described by, again, Berlemont and Weiss from Europe, but was standardized and popularized by Ernest Burgess at the PRS in his classic 1968 article, which I've referenced on this slide. The benefits of the IPOP in descriptive studies include a lower percentage of significant limb complications and few surgical revisions, as well as a short interval to custom prosthesis fitting. Others have also reported that patients are emotionally less troubled after surgery because the presence of a prosthetic foot aids in self-imaging. There are several descriptive studies that also claim that the IPOP method results in less pain, reduced edema, and reduced rehab times ranging from 9 days to 17 weeks. Disadvantages include the reduced access for wound inspection, tissue necrosis because of incorrect wrapping of the gauze bandage, or mechanical tissue trauma inside of the cast, and the requirement of a skilled prosthetic management team to do this right. However, once again, these claims are from descriptive studies, and there are no comparison groups, and it may also represent poor technique in those groups. So Burgess, Romano, and Zettel have described a standardized process for the IPOP. A rigid dressing with a temporary prosthesis is actually fashioned in the operating room after the amputation has been performed on the operating room table. And post-op day 2, the patient is allowed static weight bearing of up to 20 pounds for 1 to 5 minutes with the assistance of a physical therapist. Post-op day 3 and 4, ambulation between parallel bars or with a walker has begun, usually twice daily, up to 20 pounds of weight bearing. The first cast change is made in standard risk patients on about post-op day 10 for an above-knee amputation and post-op day 12 for a below-knee amputation. At that time, at the discretion of the surgeon, the sutures can be partially or completely removed. Alternatively, for patients who have impaired wound healing, the first cast change can be put off for 2 or 3 weeks after the operation. reliable patients can actually be discharged to home to undergo gait training as an outpatient even before the first cast change. And others can be transferred to an extended care facility with nursing care and physical therapy. And so both of those can reduce inpatient hospital stays. And that was actually something that Dr. Burgess was doing back in the 60s. The biggest concern with the IPOP is wound breakdown, particularly in elderly dysvascular patients. However, Burgess's only prerequisite for the IPOP was that there was the potential ability for the patient to stand and ambulate with assistance during following surgery. The age range in his 1968 report was from age 4 to age 86 and included patients with hip disarticulations, and the majority of his patients were vascular patients. You can see this gentleman here is shown from Burgess's article in 1968, and he's 80 years old and looks like your average Middleton VA vascular amputee. This is the prefabricated pneumatic postoperative prosthesis, and it's basically just a pre-made IPOP. The use of this prosthesis was introduced in Australia by Little in 1970 to allow for easy removal and residual limb inspection, which is one of the downsides of the IPOP. It essentially allows the advantages of the IPOP for early ambulation without the need for fabricating the prosthesis. So, its advantages, like the IPOP, are reduced edema, early weight bearing, but the benefits are that it's lightweight, it's prefabricated, so you don't have to have somebody on site making the thing, and it's removable, so you can look at the wound more frequently. Disadvantages are expense, but there may be some cost benefit because you don't have to have specialized staff to fabricate the thing. Yang-Chi Wu from the Rehabilitation Institute of Chicago and Northwestern has been the pioneer of the short, removable, rigid dressing. And this is actually the dressing that most rehab docs prefer, including several of the ones at our institution. His group from the Lakeside VA in Chicago first reported on the removable rigid dressing in 1977. The advantages of the RRD include reduced edema, reduced pain, possibly decreased healing time, wound protection because of the rigid nature of the dressing, the ability to bear weight, and the fact that it's removable, so you can inspect the wound more frequently. Disadvantages are that it has to be fabricated. Again, I think it's made in the operating room, and there is a higher cost because it requires specialized people to do it. The RRD consists of 4 components. So the first one here, labeled A, are tube socks. And then you make a below-knee plaster cast right here, letter B. C is a suspension stockinette, so you put the sock on, you put the cast on, and then over the cast you put this long stockinette. And then you place this PVC supracondylar cuff, which actually goes above the knee, and then you wrap the top of letter C over, and that helps fix the dressing above the knee. These pictures show the 6 to 8 easy steps for donning the dressing. So when you talk about taking a prosthesis on and off, it's called donning and doffing. This can easily be done by the patient, as you can see in this picture from Wu's book chapter that shows the patient actually putting this on. The technique provides the transition between molding the residual limb and using preparatory prostheses that lies between the more conservative soft dressing and the more aggressive IPOP. In his initial 1977 report, Dr. Wu described 16 patients treated with the RRD and compared their outcomes to historical controls. He reported a decrease in time to healing from 110 days to 46 days, with ambulatory discharge occurring 90 days sooner than his controls. Another better controlled trial also demonstrated significantly decreased edema compared to soft gauze dressings. I'm going to switch gears now and talk about briefly about some of the outcomes after major amputation. These figures are from the Task 2 guidelines, which give some insight into early and late outcomes of vascular patients, and frankly, they're pretty dismal. You can see on the left here, this is the early postoperative outcomes, and again, these are all comers, and it's a little bit old data, but I think it still holds for today. They report about a 60% primary healing rate and a 15% secondary healing rate for an overall healing rate of about 75%. 15% will be converted to an above-knee amputation, and like I mentioned before, 10% mortality in 30 days. When you look at after 2 years, 50% 15% are going to have a contralateral amputation. Again, 15% with an above knee amputation, and again, I don't know if it's totally surprisingly, 30% are going to be dead. Only 40% are going to have full mobility. If you look at this as a survival curve, you can see that the higher the level of amputation, and this is in vascular patients, the higher the level of amputation, the worse the survival. If you look at 5 years after survival for transtibial, which is the second to bottom line in the transfemoral, you can see that the survival curves tend to resemble many cancer curves. I think Dr. Cho probably already picked up on that. Survival after amputation is reduced in patients with renal disease, which I think would be pretty much expected. And survival after amputation is reduced in patients with cardiovascular disease, which really represents a lot of vascular patients. They have both renal disease and cardiovascular disease. So overall, I think it's time to change the way we think of major lower extremity amputations. It's commonly an intern procedure, and it doesn't get it's not very sexy. We don't really talk about it very much, but I think it's time to think of it in a different light. If major lower extremity amputations were included in the 11 most high mortality operations performed in the national Medicare population, using data from M-SCORE and Justin Dimmick and his colleagues at University of Michigan, it would be in the top 5, comparable to a pancreatectomy. Most people in this room would agree that the 4 operations in red, esophagectomy, pneumonectomy, gastrectomy, and pancreatectomy, should be performed by high-volume centers, by high-volume surgeons to ensure good outcomes. We have bariatric centers of excellence for the multidisciplinary practice of weight loss surgery, regional trauma and burn centers that undergo intense accreditation processes, and comprehensive cancer centers. And in fact, our institution has all 4 of those. All of these areas of surgery have undergone a major paradigm shift, transitioning from the individual practitioner to regional centers with multidisciplinary programs. I argue that amputation surgery is due for a paradigm shift as well, moving from fragmented care performed by individual practitioners to regionalized specialty care with multidisciplinary programs. And we already have a model for how to do this. So this is the Center for the Intrepid at the Brooke Army Medical Center in San Antonio, Texas. It's possibly the most state-of-the-art rehab institution in the world. In 2004, the Department of Defense began a paradigm shift in their care of amputees, prompted by the influx of amputees from Iraq and Afghanistan. And what they did was they centralized their amputation care to 3 institutions which were open at that time. Walter Reed Army Medical Center, or RAMC, in Washington, D.C., which at the time was the flagship. Brooke Army Medical Center, which has the Center for the Intrepid that I showed before, in San Antonio, Texas, and the Naval Medical Center in San Diego, California. I think that Walter Reed has now been transitioned to Bethesda, which happened in August of 2011. The mission for the Department of Defense amputation care is to provide the highest quality of care to these men and women who are willing to put their lives in harm's way in support of their country. And their vision for their centers of excellence is that through collaboration of a multidisciplinary team, we will provide world-renowned amputee care, assisting our patients as they return to the highest levels of physical, psychological, and emotional function. So this man here on the right is Paul Pasquina, and he's been one of the driving forces of this paradigm shift. He's a physical medicine rehabilitation doctor, and he actually heads the amputation program or headed it at Walter Reed Army Medical Center. In this statement on his idea of what a center of excellence should be, he describes it as being holistic, comprehensive care, having an emphasis on early rehabilitation, providing interdisciplinary teamwork, continual education, providing sports and recreational activities to the amputees, and keep in mind these are mostly young men, and maintaining a therapeutic milieu. And they also provided active research. I'll go through this. There's really only 2 things you really need to see here. This is the patient flow chart for combat amputees that arrived to RAMC. So under the leadership of Colonel Pasquina, they created a dedicated amputee inpatient service as well as a separate outpatient amputee clinic. both under the management of PM&R. Following a rehabilitation model, the physiatrist functions as the primary provider for the amputee, coordinating recommendations and interventions from various medical and surgical subspecialties, therapists, nurses, prosthetists, etc. So when the patient arrives at Ramsey, they're triaged, and if they're brought into the inpatient service, because a lot of these patients are multiply injured combat amputees, they'll end up on an inpatient service, but the goal is to have an early PM&R consult within 24 hours. And then overall, the goal is to have the patient transferred to the amputee service where they're actually primarily cared for by rehab docs. And then the surgeons and the other specialists actually function as consultants. The rehabilitation team assists the surgeon in determining amputation length and level. The prosthetist is involved preoperatively to ensure optimal limb length prosthetic fitting and function. So what are the outcomes for this paradigm shift? Well, it's too early to know what the overall outcomes are for all patients, but this is one anecdote. This is Heath Calhoun. While deployed in Iraq, Calhoun served as the squad leader for the 101st Airborne Division. While riding in a convoy, his Humvee was struck by a rocket-propelled grenade. The explosion killed one soldier and severely damaged Calhoun's legs, necessitating the amputation of both limbs above the knee. He spent the next 9 months recuperating at Walter Reed Army Medical Center. During his rehabilitation, he learned to walk on prosthetics, and then he learned about the Wounded Warrior Project, which provides programs and support for injured service members. And so through that, he learned how to swim, ski, ride a bike, and run with the use of some pretty advanced prosthetics. The other interesting thing is that these amputees are now actually returning to active duty, and surprisingly, this was actually happening as long ago as the 1980s, although these patients were not actually getting involved in combat. However, Captain Dave Roselle, who's pictured in this slide here, of the 3rd Armored Cavalry Regiment, became the Army's first amputee from a wound suffered in Iraq to return to active duty, and this is him with his prosthesis actually in Iraq in active duty. He recounts the experience in a memoir, Back in Action, an American Soldier's Story of Courage, Faith, and Fortitude. The Department of Defense has partnered with the VA to transition amputees from the Department of Defense into the VA setting for their long-term care. And in doing this, the VA has actually undergone its own paradigm shift. So they received funding for this in 2008 and actually implemented it in 2009. And I didn't know this until I started this talk. It is the VA, so they have lots of acronyms, and each level of care has its own acronym, and I'll go through them briefly. So this is from the VA, and it's hard to see the light blue, but I'll just go over it quickly. So the dark blue stars are the Regional Amputation Centers, or RACs, and these are the banner facilities for amputation care in the VA, and are comprised of physicians, therapists, prosthetists, nurses, mental health professionals, social workers. They have the highest level of expertise in clinical care and are equipped to provide the care for the most complex cases and have the most developed prosthetics laboratories, rehab facilities, etc. The closest RAC to our VA is in Minneapolis. The second level of care is the Polytrauma Amputation Network sites, or PANS, and these provide the full range of clinical and ancillary services and are consultants to other facilities within their VISN. So each VISN has one of these sites, and the one closest to us is in Hines, Illinois. The Amputation Care Team, or ACT, are located in smaller VA facilities that may not have the full range of supportive services available to the other higher levels of care, but they're located more conveniently to the veteran's home and can provide for the majority of the run-of-the-mill amputation care and healthcare needs, and prevent or eliminate the need for the veteran to have to travel long distances. There are about 100 ACTs across the VA healthcare system. And then the last level of care is the amputation points of contact, and these are actually individuals who are assigned to the amputee. They're either a nurse or a social worker, and they can refer the veteran to a component of care best suited to meet their needs. So they're sort of like a transplant coordinator for the amputee. So do we need amputation centers of excellence? I believe that we do. And the potential benefits are improved mortality, improved morbidity, improved functional outcomes, reducing costs, and to facilitate research, which is actually very much needed. So I'll now take any questions.